Dear friends, dear colleagues from East and West, it's a pleasure today to have our webinar of the International School for Gynecologic and Reproductive Endocrinology dedicated to the menstrual cycle disorders themes. Today we will have a very important session who will speak about the role of progestogen in menstrual cycle related pain disorders. And to have two important speakers today, Professor Charles Sultan. This is Professor of Pediatric Endocrinology, University of Montpellier. He has a pediatric endocrine and gynecologic unit. He is the recipient of the Andrea Prader Prize, which is the highest recognition in pediatric endocrinology. We make our compliments. He is currently board member of the International Society of Gynecological Endocrinology. He is also a member of the editorial board journal of the European Gynecology and Obstetrics, Gynecological Endocrinology, and the Gynecological and Reproductive Endocrinology and Metabolism, our new open access journal. He will speak about the importance of dysmenorrhea. And then we will have a second speaker that I will introduce later on, which is Professor Stefano Luisi. Now, Professor Charles Sultan, you have the microphone. After you, I will introduce Professor Luisi. And after Professor Luisi's presentation, we will have a general discussion. Please write your question in the question and answer. This is the important. Then I will read your question and Professor Sultan and Professor Luisi will answer. Now, Charles will speak about the role of progestogen in the management of adolescent dysmenorrhea. Please, Charles.
Good afternoon, Professor Ghileggiani, dear friends and colleagues. I'm very honored to participate to this meeting, to this webinar. And I would like to thank Professor Ghileggiani for having invited me to speak about an old topic in adolescent gynecology, a very common one. And I will try to revisit adolescent dysmenorrhea. This was actually a part of my first interest when I was assistant professor in adolescent endocrinology and gynecology. And you will see that some ideas are still of interest, but others have moved. So thank you for giving me this opportunity to talk about the role of progestogen in the management of adolescent dysmenorrhea. Oh, ça marche pas. So within these 40 minutes, I will, this is a general outline of my talk. I will remind the definition of adolescent dysmenorrhea. What is its clinical expression? What do we really know about epidemiology? Some words about the pathophysiology, and I will focus a little bit more on management of dysmenorrhea and the role of progestogen in this management. What's the follow-up? Any prevention? And a few words of conclusion. First of all, what's the definition of dysmenorrhea? I'm convinced that most of you are familiar with adolescent dysmenorrhea and its definition. Everyone must know that dysmenorrhea is menstrual pain in the absence of any pelvic pathology. That's the reason why we talk about primary dysmenorrhea. That's different from secondary dysmenorrhea acquired, which is developed after on anatomical factor such endometriosis, leiomyoma, and adenomyosis and other disorders. So primary dysmenorrhea appears without any pelvic pathology. But has actually, since it's pelvic pain, the differential diagnosis is sometimes difficult, since pelvic pain may appear in this adolescent with ovarian cyst, which is during the pubertal period is not rare. Pelvic pain can appear if there is some pelvic inflammatory disease, some outflow tract obstruction, some Mullerian duct abnormalities, or genital infection. So the first message, primary, yes, without pelvic abnormality, but don't forget that there is a differential diagnosis, which sometimes is not as easy as we think. This is a beautiful review, not very old, taken from Human Reproduction Update, that clearly pointed out one or two key issues in adolescent dysmenorrhea. The first factor on the right part and the high part of the slide, that we have to consider that dysmenorrhea occur in some privileged family. There is genetic factor, and I remember in my experience having to manage several familial dysmenorrhea with one or two adolescents and their mother having dysmenorrhea. So there is a genetic background of adolescent dysmenorrhea. As a matter of fact, a recent paper reported recently a gene polymorphism of one factor involved in the development of pain. So there is obviously a genetic background, a genetic environmental factor. This recurrent menstrual pain induced is associated with a low quality of life, with a low sleep quality, with physical activity. It induces poorer mood, and all these associated factors, we don't know if it's a consequence or maybe a cause, a contributing factor to dysmenorrhea. What we do know that this recurrent menstrual pain is related. There are more and more data that clearly demonstrate that there is an increased sensitivity to pain in this adolescent with dysmenorrhea. Increased sensitivity to pain, which is very common, especially in adolescent female, but it's particularly notable in this girl with dysmenorrhea. Why? Because there is some evidence of central nervous system change, cerebral metabolism, some different cerebral structure has been reported to contribute to this predisposition to chronic pain. So in other words, we will see later on that dysmenorrhea is a peripheral disorder associated with brain sensitivity, abnormal sensitivity to pain. So what the definition? Definition, well known, as I mentioned. As I already mentioned, the different diagnoses, but one main question that occurred within the last years is the link between dysmenorrhea and the diagnosis of endometriosis. And the first, in my opinion, the first take-home message is the following one: is primary dysmenorrhea a risk factor for the diagnosis of endometriosis? Actually, when I was a resident or assistant professor, we used to consider that endometriosis did not start during the pubertal period. This is actually a wrong concept. And that's the reason why many group leaders consider that primary dysmenorrhea may be a risk factor for the diagnosis of endometriosis. This is a work, recent work, coming from the Boston and Mark Lawfer, which is an opinion leader in adolescent gynecology. He pointed out that there are two symptoms that could be considered as a signal for the development of endometriosis, and namely there are nausea and symptom onset are menarche. So when dysmenorrhea, we will see later on that usually dysmenorrhea occur some months after menarche. If it does occur at the time of menarche, it could be a sign of endometriosis. And more recently, a few months ago, another opinion leader, Felice Petraglia, which is a close collaborator, who was a close collaborator to Professor Gelazzani, wrote a beautiful review when he reported the same question dealing with: is primary dysmenorrhea a precursor of future endometriosis development? In other words, conversely to our past experience, we should not consider anymore the primary dysmenorrhea as a common symptom. We should keep in mind that it may be the first diagnosis of the first symptom of the development of endometriosis. What is the clinical expression? As you can, I wrote 20, 30 years ago a review in which the title was Dysmenorrhea, a symptom or a syndrome? As a matter of fact, it can be both. Whatever, it's a syndrome since it's characterized by several clinical manifestations. The second message I would like to share with you, that conversely to what is usually written in books, primary begin when adolescents attain ovulation. That means ovulatory cycle, that means 6 to 12 months after menarche. And this is confirmed by the consensus meeting published by the American College of Gynecologists and published a few years ago. So the pain starts within few hours of men's onset and lasts usually 4 to 5 days. In some cases, primary dysmenorrhea is preceded by premenstrual syndrome. We don't know, although there are several reports, what is the link between premenstrual syndrome and dysmenorrhea. Maybe it's the same syndrome, but we don't know, since the pathophysiology of premenstrual syndrome is quite different to that of dysmenorrhea. Another point that appears during the last year, that the intensity of cramps, of cramp pain is variable, and it's associated with systematic syndrome, headache, nausea, we will see. But a very important concern is its association with school absenteeism, and this has been evaluated in terms of the money lost by this school absenteeism, evaluated in millions of dollars. Don't forget that dysmenorrhea is also associated with anxiety and psychological problems. The problem that I discovered 30 years ago with dysmenorrhea, that we didn't have a rating scale for dysmenorrhea, not only to standardize the assessment of dysmenorrhea, but also to evaluate objectively the efficacy of therapy. And that's the reason why we proposed 20, I think it's 20 to, I don't remember exactly, some years ago, we proposed a rating scale for dysmenorrhea. And this rating scale is based on the respective symptoms associated with dysmenorrhea, such as pelvic pain, low back pain, headache, nausea and vomiting, diarrhea, asthenia, irritability, dizziness, myalgia, faintness, and absenteeism. So according to the intensity of each of these symptoms, I score very severe 3, severe 2, and moderate 1. And the addition of all these symptoms lead to a total around 10 can consider the dysmenorrhea as moderate. Around, I'm sorry, there is a mistake. 23, not 13, but 23, the dysmenorrhea should be considered as severe, and 35, the dysmenorrhea is considered as very severe. And in my opinion, this scale could be very helpful to compare the prevalence, the efficiency of treatment, the repartition of dysmenorrhea in the country according to the culture, to the socioeconomic, and so on. So this scale, in my opinion, could be very helpful for gynecologists. Regarding epidemiology, I was very surprised when I was younger to discover a huge variation in the prevalence of dysmenorrhea. Since, according to the report, this prevalence ranged from 20 to 93%. And that's the reason why we decided to perform scale. And using, due to this wide variation, we perform epidemiological data in France, in the Montpellier area, which is part of the south of France. The first study was done 40 years ago, and based on a collection of 4,203 adolescent girls from a college. And we found the overall prevalence of 21% of these girls did present dysmenorrhea. And if we compare with the data from the literature at that time, Anders found 20%, David Elia 35%. And due to this discrepancy, 20 years later, we performed another epidemiological study on 912 adolescents from another college. And we found, and this is, in my opinion, an important message, that severe dysmenorrhea with a score above 30, 25 to 30, did occur in 37% of adolescents. So severe dysmenorrhea occurs in 1/3 of adolescents from the age of 13 to 18 years old. What's interesting, in this epidemiological study, we confirm that prevalence of dysmenorrhea increase, as we mentioned 20 years before, in the late 80s, that the prevalence increase with gynecological age. This, in my opinion, it's an important message. It's ran from 9% to 18, 20% after a gynecological age of 3. What is the pathophysiology of adolescent dysmenorrhea? Everyone, I am sure among you, are aware on the, I should say, the key factor responsible for adolescent gynecology, which is the overproduction of prostaglandins. So it was reported some years ago that adolescents with dysmenorrhea did present an increased level, an increased production of 2 prostaglandins, PGF2 alpha, mainly, and another prostaglandin. And this occurred during the menstrual period. And we know from clinic, epidemiologic, and experimental data that this increased PGF2 alpha is a promoter of adolescent dysmenorrhea. But the primum movens of this increase has been identified long time ago, which is the decrease, the fall of progesterone level that occur just before menstruation. And it's the decrease of progesterone that is responsible for liberation of metalloprotease, which destroy the membrane, liberate fatty acid. But besides, there are other production of inflammatory factors, such as cytokine. As you can see on this slide, low progesterone level induce a liberation of metalloprotease, of collagenase that open the cell and release phospholipid that under the action of phospholipase ADE produce arachidonic acid, which under the action of COX-1 and COX-2 induce synthesis of thromboxane, PGE2, PGF2 alpha, and prostacyclin. And the main prostaglandin involved the uterine contractility are PGE2 and PGF2 alpha, as I mentioned before. I think this is a nice scheme that clearly demonstrates that the low level of progesterone increase lability, of the cell, which liberate phospholipid and so on. And PGF2 as well as PGO2 increase contractility, induce arterial and vasoconstriction associated with endometrial ischemia and dysmenorrhea. So, as you can see, I should point it out because this is the basis of progesterone treatment of adolescent dysmenorrhea. In the fall down, the drop of progesterone that occurred just before menses, that induce, as you can see on the right part of the slide, in the cell, a liberation of protease, such as metalloprotease, which induce a proteolytic breakdown and liberation of phospholipid. And simultaneously, the fall in progesterone liberate COX-2 that are able to stimulate prostaglandin and induce both vasoconstriction and inflammation. So the primum movement of adolescent dysmenorrhea is the decrease, the drastic decrease of progesterone that occur in early menses. I think this slide may be more interesting. You can identify the different factors involved. The low progesterone, if progesterone decrease, it induces an alteration of cell membrane, liberation of arachidonic acid, and cyclooxygenase, lipooxygenase will induce synthesis of prostaglandin involved in ischemia and pain, abdominal and pelvic pain. How to manage adolescent dysmenorrhea? In my long experience, we treat thousands of girls with dysmenorrhea. Non-steroidal anti-inflammatory drugs have been proved to be the preferred initial treatment for dysmenorrhea, and particularly in non-sexually active adolescents. And in my experience, but this can be discussed or contested, I use ibuprofen 400 to 600 milligrams every 6 hours but we have to respect the maximum daily dose, which is 2,400 milligrams. And these non-steroidal anti-inflammatory drugs should be prescribed for 2 or 3 days. And this is a very efficient treatment. If the treatment with non-steroidal anti-inflammatory is not effective, so hormonal treatment should be offered, especially in case of menstrual disorder. I did mention in our both epidemiological study, we pointed out that many of adolescent girls with dysmenorrhea did present menstrual disorder. That the reason why dysmenorrhea associated with menstrual disorder, they need progesterone. It has been proved very helpful, or progestative contraceptive pill. The progestin only medication are represented by retroprogesterone, levonorgestrel intrauterine device, or oral progestin, such as norethindrone, 5 milligrams per day. But hormonal therapy could be also be prescribed in estrogen progesterone contraception, given as pill, as a ring, or a patch. In my experience, I usually prescribe one of the progestin or estrogen progesterone contraception as a first-line therapy for 6 months. This, I don't have time to go into detail and to mention all kinds of progestogen. But what's interesting that some of them has been checked for their affinity to the receptor. But since this slide will be shared with you, you could read it carefully later on. So as I mentioned, the progesterone can be used in different forms. Orally, has a 3-monthly injection, or as an intrauterine device using levonorgestrel releasing. We have in clinic, at least in France, different type of progestogen, dihydroprogesterone, medroxyprogesterone acetate, chlormadinone acetate, dienogest, and drospirenone. As you can see, when you decide to prescribe a progestin only, we can choose between norethindrone acetate, 5 to 15 milligrams daily, medroxyprogesterone acetate, 30 to 50 milligrams daily, dienogest, 2 milligrams, or depot medroxyprogesterone acetate, which is not given orally, but by intramuscular injection, 1 injection every 3 months or 4 months, it depends on the tolerance. As you can see, this is a work I was involved in, which evaluate the efficiency of different progestogen on the production of prostaglandin F2 alpha in adolescent with dysmenorrhea. As you can see, this group checked the efficiency of chlormadinone acetate, Dienogest, and drospirenol. And what happened? It appeared that clomidine was the best treatment was the most efficient treatment to decrease the production of PGF2 alpha in this adolescent. It decreased the production by more than 50%. While other progestins were also efficient. Just to remind you that I don't have any conflict of interest with Bilara and so on, pharmaceutical field. So this is a very interesting data recently published in JAMA, which is our Bible, dealing with the management of primary dysmenorrhea, and you will check that we are not far from this counseling and from this kind of consensus data. So, in the presence, or when we have to face for an adolescent with dysmenorrhea, we should start by non-steroidal anti-inflammatory drug, ibuprofen, 400 to 600, I agree. And we start this treatment with onset of symptoms, I agree. And we continue until day 2 to 3 of cycle, I agree. We also, in some conditions, when the adolescent need contraceptive, we may prefer hormonal therapy based on estrogen combined contraceptive. Or we can also propose progestin-only medication, like such as levonorgestrel intrauterine device. Etonorgestrel, I don't have any experience with this. Oral progestin, such as norethindrone, 5 milligrams daily. The second, the important message that we have to reassess this situation at 3 to 6 months. Usually, I prescribe a treatment for 6 months. If there is a positive response to this treatment, primary dysmenorrhea diagnosis is likely. If there is a suboptimal response, we have to evaluate this adolescent for secondary dysmenorrhea, pelvic examination, pelvic ultrasound, and we have to refer to a gynecologist, which is able to perform the examination for endometriosis. This is, I wanted to compare with the consensus meeting and the proposal from the American College of OBGYN, and was published some years ago, which is very close to the previous statement. As you can see, in front of an adolescent with dysmenorrhea, we start treatment. And if it does respond, we continue, and the diagnosis of primary is confirmed. We continue the treatment for 3 to 6 months. If it doesn't respond, you should consider as secondary dysmenorrhea with the need to perform other investigation to identify the cause of this secondary dysmenorrhea. So, the JAMA paper published the last year, as well as the consensus meeting supported by the American College of OBGYN, are both concordant with this approach, which actually is very simple and logical. But there is, beside the drugs, there are, when you manage, there are complementary therapies. And in France, and maybe I'm sure in many other countries, a lot of adolescents, high percentage, use complementary therapy. Heat therapy, exercise, some of them use dietary supplements such as fenugreek, ginger, valerian, fish oil, vitamin B1, vitamin D, or herbal preparation. There is a lot of herbal preparation, but according to the Cochrane database, none of this complementary therapy has been scientifically evaluated versus medical therapy. Similarly, there are some alternative therapy, such as transcutaneous electrical nerve stimulus, acupuncture, which has been very useful in some papers, as well as yoga, that can be used in this adolescent. But as I mentioned, for complementary therapy, this alternative have not been evaluated, scientifically evaluated versus medical treatment, and Cochrane just mentioned, but don't advise this alternative therapy. One of my main message is this one. Conversely to what we did in clinical practice in the past, I think we have to follow adolescent girls for dysmenorrhea. If primary have disappeared, if we convince that it was a primary dysmenorrhea, we are reassured. But if the dysmenorrhea continues, if it's resistant to treatment, follow-up of this adolescent is necessary, especially when adolescents report progressively worsening dysmenorrhea. If she reports abnormal uterine bleeding or heavy menstrual bleeding, that we discussed the last month with Professor Ganazzani in another webinar, or if the adolescent complain with mid-cycle or acyclic pain. So this condition should be mentioned, since it was not the rule in the past to follow this kind of resistance of low or bad responding adolescent with dysmenorrhea. So especially when there is a low or lack of response to medical treatment, one should suspect secondary dysmenorrhea and mainly endometriosis, and this adolescent should be referred to OBGYN. Can we prevent? This is a new aspect of dysmenorrhea. Actually, exercise has been proved helpful, but it has not been scientifically evaluated. What do we know? That smoking cessation should be advised, since smoking is a risk factor for dysmenorrhea. And according to the Cochrane, behavioral intervention can be discussed since in some conditions, in some cases, they have been proved helpful. What can we conclude? So this comes from the general review published in Human Report that resume all I previously mentioned: medical history, the response, the intensity of pain, and the eventuality of the resistance or the persistent dysmenorrhea that raised the question of the second dysmenorrhea and the risk of developing endometriosis. There are several years, according to adult gynecologists, they complain about the long period of prolonged dysmenorrhea without any advice to the gynecologist. So, a conclusion, many, I should say 50% of adolescents never seek medical attention for dysmenorrhea. 2, self-medication are common effective strategy in many cases, according to the culture, the social class, to the whatever you want. I strongly believe that grading dysmenorrhea may help guide the treatment strategy. Medication may include non-steroidal and hormonal treatment based on progesterone, since it's the primary movement of the dysmenorrhea development. And last, as I mentioned several times, adolescents with persistent dysmenorrhea or refractory symptoms, this adolescent need a consultation with a gynecologist. Mr. President, dear friends, colleagues, thank you for your attention from Montpellier, the city who are very proud to have the oldest school of medicine in the world. Thank you.
Thank you, Charles, for a very extensive, well done, and very educative lesson. And now you have to wait the Stefano Luisi presentation, then we will have the general discussion. And then it's now my pleasure to introduce you Stefano Luisi. Stefano Luisi is Associate Professor of Obstetrics and Gynecology at University of Siena. He has been awarded for Bruno Salvadori for prenatal medicine and the Endocrine Society Pfizer Inch for excellence in published clinical research in JCEM, and is member of the editorial board of the Journal of Endometriosis and Pelvic Pain Disorders, the Journal of Endocrinological Investigation, Gynecological Endocrinology, European Gynecology and Obstetrics, and the Gynecological and Reproductive Endocrinology and Metabolism. And Stefano Luisi is with us today, and he will speak about the second chapter related to role of progesterone in menstrual cycle-related pain disorders, who is endometriosis and adenomyosis. Please, Stefano, you have the microphone.
Yes, good afternoon, everyone. Thank you very much to Professor Genazzani for this kind invitation. I also compliment to Professor Sultan for your presentation. You see my slide, please? Yes, okay.
No, we don't see the slides.
Okay, sorry.
It happened.
Okay, now it's okay.
Perfect.
Okay, thank you.
Beautiful image of Siena.
Siena, okay. My presentation today is the role of progesterone, the treatment of endometriosis and adenomyosis. And say before, Professor Sultan, is a big problem that starts with adolescent with dysmenorrhea, and then in the second part of adolescence and in younger women, we have dysmenorrhea in endometriosis and adenomyosis. Regarding the progesterone discovery is in the 1930 when Adolf Brunner isolated 3 sex hormones: female estrone, progesterone, and male androsterone. And this is the history of exogenous progesterone, from natural progesterone to synthetic progestin, then natural microneedled progesterone, until 10 years ago with natural microneedled synthesis release progesterone. So now move to which are the clinical application of progesterone. In obstetrics, we know that it is important to treat abortion, recurrent abortion, preterm delivery, and gynecological disease. There is a lot of disease, and endometriosis and adenomyosis are very important because the pathogenesis of this disease probably is a upregulation of progesterone receptors. We know that endometriosis is a common benign estrogen-dependent chronic gynecological disorder characterized by the presence of a uterine endometrial issue outside of the normal localization. And we have 3 different types of endometriosis. We know the endometriosis of ovary that we can call endometrioma, and then 2 different peritoneum endometriosis, in particular the superficial peritoneal endometriosis and the deep endometriosis to the bowel, bladder, or ureter. Endometriosis is a disease with high impact on women healthy, and for many women, endometriosis has a negative impact on the ability to work, on family relationship, and self-esteem. And the American Society of Reproductive Medicine defined as endometriosis should be viewed as a chronic disease that requires lifelong management plan, with the goal of maximizing the use of medical treatment and avoid repeated surgical procedures. And which are the symptoms of endometriosis? There are the symptoms related to the menstrual cycle, and we have dysmenorrhea, dyspareunia, dysuria, and dyschezia. But also there is a chronic pain, which are chronic pelvic pain and IDH. And why there is chronic pelvic pain? Because in this slide, Morotti show very well that the peripheral pelvic pain through the dorsal root ganglia arrive to the central system, nervous system. In particular, we have an increase of interleukin 1, 6, 12, COX-2, chemokine, and this is possible because there is an increase of neuronal growth factor. And here there are the women's limitation, in particular, work activity, sport activity, the sleeping, but very important is the sexual relationship. Because in the USA, endometriosis represents the break married, is one of the most important causes of break married. And it's very also important to understand the management of endometriosis because it's a chronic disease. So when we have make the diagnosis with ultrasound that is sufficient, in Italy we have a very colleagues that are very high levels to diagnosticate endometriosis and adenomyosis. And when we decide, we have 3 different choices. To the infertility clinic, if there is not possible to have a pregnancy spontaneous pregnancy, the laparoscopy surgery, if you have, for example, an endometrioma, or probably in some cases when there is young women, the medical treatment is the best choice. But it's very important, to understand also that the follow-up after in the years after the treatment is very important. We have 4 probably different forms of endometriosis, because also adenomyosis is a part or not a part of endometriosis disease. We know that we have a combination of different forms of endometriosis. In particular, we know that endometrioma and deep endometriosis is together 40%. Home and peritoneal lesion is 30%. Home and adenomyosis 40–50%. Deep endometriosis and adenomyosis 70%. So the problem is that after surgery, the recurrence of pain and the recurrence of lesion also is very high if we not make a medical treatment after surgery. And in the last years, 10–15 years, our colleagues that make only the surgery have a big problem, because after 1 year in the follow-up, there is again pain or again the lesion in 20–50% of treated women with surgery. And so, which is the role of progesterone? We know now that the degrees of progesterone receptor activities is probably the main causes of pathogenesis of endometriosis. And we know in this slide that there is a progesterone resistance that activated the proliferation of cells on the endometriosis foci. The progesterone resistance have a role in increasing inflammation and a negative impact on apoptosis. So we have an increase of endometriosis. But we know that progesterone is efficacy because is a long-term efficacy, and there is very, very slow side effect. So this is one of first our paper published in 2007, in which we use 6-month desogestrel treatment that protect by endometrioma recurrency. And we can see here the 20 patients before and after 6 months of treatment. So we can conclude in this study that there is a good option with this progesterone, but is off-label. Again, Paolo Vercellini in the same year published this paper with the low-dose noritestosterone acetate in this is in violet and not in red, sorry, but the color is not bad, not good, sorry. And also the use of ethinyl estradiol plus cyproterone acetate. And we can see here that there is a significant decrease on dysmenorrhea and deep dyspareunia score for the for 2 different drugs, progestin and estroprogestin. But this is probably a best paper because here there is in red a group of women that make surgery, okay? And we have in blue the group with progestin group. And we can see that there is a significant decrease of visual analog scale, visual score in patients with surgery that make surgery respect to progestin group. But after 3 months, there is a new increase of visual analog scale. At the contrary, in progestin group, the pain relief was more gradual but progressive during 1 year of treatment. Another point is regarding the endometriosis, in particular, deep endometriosis. And 20 years ago, Fedele from Milano showed that if you make levonorgestrel with the intrauterine device, we have, after 12 months, a reduction of the lesion on bowel or on the bladder. Again, now probably Dysmenorrhea in the last 10, 12 years is the progestin that is more experimental data on women. And the start of the story is by Strovisky, then that 12 years ago published this first paper in which there is a significant decrease in Dysmenorrhea 2 milligrams a day until 12 weeks of treatment. And the same time, in the same years, Strovisky showed that there is no different from Dysmenorrhea 2 milligrams and leuprolide acetate, and we can see here the degrees, but we can know that leuprolide acetate have much side effect. So Dysmenorrhea is better than generic analogs. And why we have a good response from Dysmenorrhea? Because Dysmenorrhea improve progesterone resistance, and we can see here the control group and the group with Dysmenorrhea. And this paper is about published 10 years ago. Then there is a lot of paper after that give us the antiestrogenic effect of Dysmenorrhea regarding the reduction of cell proliferation, the inhibition of local aromatase, as we can see in the slide. But also there is a pro-apoptotic effect because Dysmenorrhea block the production of NF-κB, and so we have the promotion of the increase of apoptosis with cell death. But also, as we can see Professor Sultan before, anti-inflammatory effect, because Dysmenorrhea have a good inhibition on COX-2, but also on prostaglandin type 2. So we have in a simultaneous inhibition of COX-2 and prostaglandin synthetases. Again, anti-neuro and vascular angiogenic effect, because Dysmenorrhea block the increase of neuronal growth factor that is responsible of pain, but also block the vascular endothelial growth factor that is the causes of migration of vessel in the lesion in the our organs. So Dysmenorrhea have powerful action, but this action is on ectopic endometrium, but also on ectopic endometrium. So we have the reduced cell proliferation, reduce the bleeding, and we have a high percent of women with amenorrhea after 6-9 months, but also decrease vascular and endothelial growth factor and neuronal growth factor, decrease TNF alpha, and decrease prostaglandin. And this is important because we have a decrease of pain in women with endometriosis. But the question is, for how many years we can give Dienergest in our patient. This is the two papers published 10 years ago. One paper published in Japan, and here Arada showed that there is an increased quality of life in a patient with that give Dienergest. Japan is the country in which there is no one capsule of Dienergest 2 milligrams, but one capsule and 1 milligrams at the morning and 1 milligrams in the night. And here, in 1 year later, a group of hospitals in Europe and also Siena collaborate to this project, in which we show that there is the pain relief. Here we evaluated 65 weeks, so more than 1 year of treatment, but also we show in that after the treatment, if after 65 our women want a pregnancy, she stopped the treatment with Dienergest, and we have after about 5-6 years in which they have not pain, so she have not dyspareunia, and so she can make a spontaneous pregnancy. Again, Sugimoto published this paper in which she go to analyze the size of ovarian chocolate cyst, and she demonstrated, showed that there is a decrease of the dimension of the size of our ovarian chocolate cyst, because there is a decrease of vascular vessels that are at the peripheral of the cyst. So this is very important paper, because for the first time OTA published 5 years of duration of observation of Dienergest treatment. And we can see here there is 568 women, and there is the recurrency of after surgery excision of endometrioma. And we can see here that the endometrioma recurrence is very high here. In placebo group is about 17%, respect to Dienergest that is only 4%. There is a paper published by Romer in Germany. It is very important because if you can see here in the slide, this is a group patient taking the Dienergest after surgery. This is a group that taking Dienergest with no surgery. There is no difference. So it's very important to understand that the first choice is medical treatment. If it is not okay, the medical treatment is we can go to the surgery room. This is a paper published with my friend Stefano Luisi in Cagliari, where we analyze the role of Dienergest in 6 patients treated for 12 months with Dienergest 2 milligrams a day. And during treatment, symptoms improve very quickly, and the nodule we have the reduction in size. So the improved symptom, the quality of life score, and no side effect, suggesting that Dienergest could be first-line medical treatment in such patient. In the same times, we publish a collaborative paper with 12 different hospitals from Milan to Palermo in Italy, and we analyze the efficacy of Dienergest to improve the quality of life in 142 patients. And first, after 3 months, there is a significant increase in quality of life. So this is the first Italian multicentral study treatment with the NHS. Paolo Bercellini also showed the different results about the treatment with nortestosterone acetate and the NHS. And the satisfaction is the same. We can see here 71, 72, but the treatment with the NHS is much tolerated with the NHS with 80% respect to nortestosterone acetate 58%. There is in this slide, I want to show you that the NHS has other progestin changing bleeding patterns. And we know that irregular bleeding patterns is present in the first 3 months in 20% of patients. But in our counseling, is important to inform patients about the possibility of bleeding in the first 3 months, and also inform a patient that bleeding is not a signal of a lack in drug efficacy. So this slide is very important during our counseling. Another point is the stress. The perceived stress scale is very high in women with endometriosis, in particular with deep endometriosis. And so in this paper published by our group in Siena 80 years ago, we show that progestin treatment is associated with a large percent of patients with the moderate perceived distress. So another way, the role of progestin respect to estroprogestin. So move now to the adenomyosis and the role of progesterone on adenomyosis. And the question is, adenomyosis is another form of endometriosis? Until now, we don't have a right answer, but we know that there is similar symptoms in endometriosis and adenomyosis. In particular, pain, so dysmenorrhea, dyspareunia, dysuria, dyschezia is present, and also infertility. But the difference until now is that in women with adenomyosis, there is all in addition abnormal uterine bleeding. We know that adenomyosis is invasion of myometrium by basal gland and stroma with the destruction of normal myometrium. And so we have has endometriosis, dysmenorrhea, dyspareunia, infertility, but again, heavy menstrual bleeding. And which is the pathogenesis of adenomyosis. Until now, there is a paper published about 10 years ago by Guo in Reproductive Science that show that progesterone receptor type B promoter is hypermethylated with concomitant progesterone receptor type B downregulation. So this is the causes of increased cell proliferation, increased infiltrative growth, and then the endometrium go along the myometrium, and then there is adenomyosis. And this is the same probably mechanism from endometriosis and adenomyosis. But another point is to understand that adenomyosis is often associated with other pathology, in particular with fibromatosis, but also with endometriosis. And as we know, that is very important. And when we have endometriosis, probably the women have also adenomyosis. When we have fibromatosis, often women have adenomyosis. So it's very important the ultrasound diagnosis of this disease. But because it's important, because in uterine fibroids, polycystic ovarian syndrome, endometriosis, adenomyosis, but also explaining infertility are responsible of the pregnancy complication. Why? Because we can have an increase of gestational hypertension, preeclampsia, gestational diabetes, also preterm birth, premature rupture of membranes, but also placenta previa, or when we have in after the spontaneous birth, after we have postpartum hemorrhage, and we can know why. Probably because these women have the adenomyosis. But the problem of until now of the management of the adenomyosis is that there are no specific indication for adenomyosis management, and we have not until now the best choice medical treatment for this disease. Also, as for endometriosis, also for adenomyosis, we have three choices. Surgical treatment that is very difficult because the best is the hysterectomy, but is not possible in women that want a pregnancy. Infertility clinic, when we have about 2-3 years, then the women that have not a spontaneous pregnancy, and so probably the medical treatment is the first choice, and hormonal is the best one. And regarding the hormonal, progestin is the first choice, because we know that also generation analogs have a good result, but we have a lot of side effects. But all of these drugs are off label. So move to paper that show that we have with the use of levonorgestrel intrauterine device, we have a reduction of abdominal bleeding, an increase in hemoglobin and serum ferritin. But also there is a pain symptoms relief, a uterine size reduction, and improve the quality of life in this patient, because the dysmenorrhea, the abdominal bleeding is very high in this patient. And we can see here that there is a degrees of abnormal bleeding after in about 80% of women after 6 months. And there is a significant decrease until 36 months of treatment with intrauterine device. Also, there are in the last years some new data about the use of etonogestrel implants, and we can see that there is an improvement in pain symptoms, and including dysmenorrhea, anemia, and the uterine volume. There is a very, very important ultrasound image that show that after 6-9 months, there is a reduction in volume of the uterus. And also, most of women who had baseline dysmenorrhea experience complete resolution of symptoms in about 80% of women. The bleeding pattern experience during the first 3 months is predictive of future, because if there is a significant degrees of an abnormal bleeding in the first 3 months, probably this is the medical treatment is okay. Our experience started many years ago with the use of vaginal danazol in the treatment of abnormal bleeding, heavy menstrual bleeding, menorrhagia in patients with adenomyosis. And we can see here that in patient after 6 months, sorry, we have a significant decrease. But just from 1 to here month, there is a significant decrease. But 6 months is low period. So our experience is 24 months, 2 years of treatment with 2 different schedules. One is a continuous daily administration of vaginal 200 milligrams per day, and 6 months of treatment, 3 months without the drugs, again 3 months, and so until 2 years of treatment. And we have a very good result, because we have a degrees of pain, abdominal uterine bleeding, uterine volume in each group, and we can have a patient that can decide with us if we make drugs every day or every 3 months, stop and then start again after 3 months. There is also in the last years some new data for medical treatment of women with adenomyosis with Dysmenorrhea 2 milligrams. In this paper, Zuga published 16 weeks, and we can see here that is the placebo group, the high of the slide. Here there is the Dysmenorrhea group. So after 1 month, there is a significant decrease. So Dysmenorrhea was effective and well tolerated in the treatment of symptoms and also in abdominal uterine bleeding. So I go to finish my presentation with this slide in which you see the management of adenomyosis. When we have a clinical presentation with symptoms, dysmenorrhea, dyspareunia, abdominal uterine bleeding, and then we have 2 or 3 dimensional ultrasound, we have some image that is very, very important to understand that this uterus is adenomyotic uterus. So we have 3 different, I make in this slide 2 different women. One is a young women that not desire pregnancy, but have pain, abdominal uterine bleeding, so medical treatment. In infertility woman, some paper show that 6 months, 9 months of treatment with progesterone is important to increase the quality of life, but also the size of uterus. If we have women over 40 years with pain, abdominal uterine bleeding, and no desire of pregnancy, we can use intrauterine device levonorgestrel. In some case, medical treatment, but is very low percent of women have not in these years after. So we have necessary surgical treatment. And I finish my presentation with this paper published by Casper on fertility sterility 5 years ago, in which he showed the role of progesterone that probably is the better first-line treatment for endometriosis and adenomyosis that combine estrogen pills. Because there are a lot of trial data that in which may do better with oral progestin in the treatment of first-line therapy, because progestin have the most benefit in reduction pain, suppressing the anatomy extent on endometriosis, and also the adenomyosis, nodular or diffuse endometriosis. And why progesterone alone? Because it can be used at any age, do not increase the risk of thrombosis, inhibit ovulation, and induce amenorrhea in very few months with very few side effects. And now I will thanks all of you, and in particular Professor Genazzani for this kind invitation.
Thank you, Stefano, for that beautiful lecture on endometriosis and adenomyosis. And then now, dear friends, we have a huge series of questions, And then I would like to invite also Charles to be with us to go to the question. I will read the question, and then I will ask both of you according to whom the question is addressed. And then, okay. Okay, then I would like to start with a question for Sultan. You were mentioning alternative therapies. What is the interest of alternative therapies?
Do you hear me? Yes?
Yes.
Okay. Thank you for this very interesting question. You know, obviously in France, there is more and more among young people, especially young women, a kind of resistance to drugs. So they prefer the so-called alternative treatment. Alternative treatment is, in very simply, treatment based or not based on drugs.
Prof. Sultan, please, could you open your video?
Just a moment. I did it, but I don't know what happened.
You should. Okay, perfect. Thank you.
It does work? Okay. So I was trying to answer your question. It's a very important point, since in France, at least, there is a kind of resistance to treatment, a resistance to drugs. So what should say a new generation prefer alternative treatment. What is this? Is herbal, new kind of diet. It's non-aggressive treatment such as yoga, acupuncture, acupressure, and so on. There are many reports dealing with this kind of alternative therapy. My only concern that they have not been evaluated against, in the case control against medical treatment. So all reports, and it's very strange because most of these reports come from, I should say, the eastern part of the world, China, Asia, Malaysia, and so on. And in Europe too, but with a lower prevalence. So yes, according to the publication, it may work, but they have not been evaluated. There is, as far as I know, no scientific report compare medical treatment versus alternative treatment.
Thank you, Professor Sultan.
It's a very good point.
And then now a question for Stefano Luisi. We'll combine several questions. For example, Alberta Yumba asks, for those who desire fertility, do we still use Dienogest? And also, Nazika Biche asks, what is the longest duration for a Dienogest therapy for endometriosis?
Also, this is two important questions because long time. We know that now there is people that, women that make Dienogest for more than 5-6 years. with no side effect, and then stop when they want a pregnancy. And it's very important to not block, not stop the endometriosis treatment, because as we can see before, the pain relief and also the endometrioma size increase. And the first question is, Professor Genazzani?
The first question was on, sorry, I will go back on that one because
Okay.
I put us already answered. The first was, there is possible use of Dienogest in women who are still waiting for fertility.
Yes. It's important that before I go to IVF, because there is not only the foci endometriosis, but also the inflammatory, and the Dienogest block the foci endometriosis, but also the inflammatory disease in abdominal. So it's very important because there is after the treatment a good quality of oocyte, a good quality of the follicle. So there is a very important treatment before IVF. Thank you for these questions.
Charles, you want to add something on that point?
Now I have a question.
Okay. If you have a question, please.
Yes. A question to my colleague, Professor Luisi. It could be a candid question. So you mentioned what is known, that there is a kind of progesterone resistance in endometriosis.
You were able to understand.
Can you explain the efficiency of Dienogest? How can you explain the efficiency of Dienogest since this compound has a very low activity for the progesterone receptor? And since there is a progesterone receptor, I should expect the need to dramatically
Charles, we don't understand well the question.
So how can you resistance?
There is sorry, Professor Sultan, but there is the problem with the connection, and we have not understand the question. And the question, sorry.
Can you summarize again the question?
Oh, yes. How can you explain? Do you hear me now?
Yes.
Yes.
Can you explain the efficiency of Dienogest since there is a progesterone resistance, and since Dienogest has a very low affinity for the progesterone receptor? How can you explain the efficiency of Dienogest?
Yes, a good question, Professor Sultan. I know that there is a few, but there are a lot of studies that show that this upregulation of progesterone type A and B is different, but from 20 years, the first paper on in vitro study showed that there is a block on progesterone receptors. So this story started very 12 years ago. So after this, also in vitro study demonstrated that there is no this upregulation, and so we have an increase of progesterone resistance, and so this is important. I don't know now because I understand your question. I don't know why if there is a few combined with on Dienogest on receptor. Until now we know, but the result in vitro and then in patient is very important because there is a decrease in vitro of cell proliferation, and in our women in pain, and also for adenomyosis, for example, in abnormal bleeding.
Thank you.
There is a question from Najib Belahi for Charles. She asked her two questions. I will combine them. Why does not primary dysmenorrhea consider also for other pathology as fibroma, polycystic ovary, and other diseases? And also, do you compare the use of supplement vitamin and iron before non-steroidal anti-inflammatory drugs and progesterone? If there are any data about this type of medication, vitamins and iron?
Iron, I don't know, but vitamin, there is a lot of data dealing with vitamin D, vitamin E, vitamins, you know, all vitamin have been prescribed to decrease dysmenorrhea. So yes, there is a lot of alternative compounds that have been in some report proved helpful, useful to decrease dysmenorrhea. So the question is yes, but iron, I don't know. I didn't see any. Maybe it does exist, but I don't know.
Thank you very much. And then now one question for Stefano Luisi. Is possible to diagnose adenomyosis with transvaginal ultrasound? And at the same time, how many, from Najeh Elahi, how many sites do you expect for control by ultrasound for, say, response month by month or every 3 months?
Yes, a good question. I know also but I have no time to give you also the very important diagnosis with the ultrasound, because with ultrasound it's possible to see the myometrial linear striation of the uterus, to asymmetric thickness of the myometrium, the enlarged uterus, and after 3-6 months of therapy, we have a reduction in volume of our uterus. And also 3-dimensional is very important, and I give you a slide with the image of, because we can have a different nodule or diffuse adenomyosis, because this is important. And 2 years ago, there is a paper published in which the author showed that there is a different grade of adenomyosis and different pain of our patient with adenomyosis. And when we give the treatment, there is a reduction on the volume of uterus, but also the degrees of pain, the abnormal uterine bleeding. So we have a correlation with the symptoms, abnormal uterine bleeding, treatment, and ultrasound.
Charles, we have a question from Michelle Moreau. She asks you about the loss of bone mass avec bronchial utilization of Depo-Provera. And she asks, it should be possible to think about the possibility to use an oral or transdermal estrogenic supplementation?
Very good point. Yes, it's a good suggestion. Although progesterone and depo-progesterone hasn't been, I'm not convinced that it did decrease the peak bone mass directly, not through the hypothalamo-pituitary ovarian axis, but adding estradiol patch could prevent any even very low bone mass activity. Very good suggestion. Yes, thank you. It's a good point.
And then also now for Stefano Luisi from Aude Béliard from Belgium. She is asking on, is there any data on the risk of meningioma with the Dienogest?
Not sorry, I have no data. I have not in literature data. I don't know.
Okay, because there is some data about cyproterone acetate and some other. And then now for Charles Sultan, Professor Sultan explained that there is a clinical score of adolescent dysmenorrhea based on the symptoms. Is this score also transferable to adults, or there are other scoring tools for adults available?
Oh, it's the same. No, it's the same score that can be applied to adults. Yes, there is no discussion about no.
And then for Stefano Luisi, is Dysmenorrhea the most widely used progestin for endometriosis and adenomyosis? Always.
A good question, Professor Giannazzani. I don't have from the pharmaceutical compound which is in the world. Probably not, because until 5 years ago is expensive. But I know that is only progestin that is studied and the experimental for the treatment of endometriosis. The other progestin that you use also before the diagnosis are off-label. So the action of diagnosis on pain, but also in the sides of the endometriosis lesion regarding the deep endometriosis is very important. So probably for this multiple action, today is the best progestin for the treatment of pain correlated to endometriosis.
Then now a nice question for Charles Sultan. How to inform gynecologists of the importance of follow-up of adolescents persisting dysmenorrhea?
It's a problem of teaching, a problem of education.
You know, it always remains a huge problem.
I was just mentioning that it's a French problem and maybe a European one, but anyway, you know, I'm a bit surprised that gynecologists don't used to consider dysmenorrhea as you know, a symptom of another disease. Since it's reported by many investigators, or it's if they refer to publication, the prevalence is so high that many gynecologists do consider dysmenorrhea as a physiological, you know, a symptom. And I think they should change their mind, and specifically in this adolescent with persistent dysmenorrhea, they should follow up this adolescent and try to diagnose earlier secondary and to diagnose endometriosis. So according to the last data, there is evidence that endometriosis starts during adolescence, start in teenager, at least for a percentage of endometriosis.
Then now a question from Guadalupe del Carmen Hernandez Ebrar. How long, for Stefano Luisi, how long you can give the treatment with progesterone? Dysmenorrhea affects bone mineralization as does medroxy. And the third, would you recommend the use of Dysmenorrhea prior to IVF, or could the anti-androgenic effect affect the pregnancy rate? I ask because I think this immunomodulatory and anti-inflammatory effect sounds good for IVF. Please, can you have...
Yes. A good question, but the colleagues respond because as I see before, the anti-inflammatory effect, but also the vascular endothelial effect is very important. Also because, as we know before, there is a lot of complication in women that then have a pregnancy, but before have endometriosis or adenomyosis, complication as hypertension, complication as placenta previa, or hemorrhage after the delivery. So it's very good question. But the analgesic for a long time, as before say, how is necessary. I think that 7-8 years is no problem until when the women want a pregnancy.
Okay, thank you. There is a question also for Sultan. You were mentioning the possible link. There is a link with with this adolescence with menorrhea and endometriosis.
Yes, but this is a new, a new concept. As I previously mentioned, when I was a resident, no one used to consider endometriosis as an adolescent disease. This has changed a lot since longitudinal study, follow-up study, especially from the American group of Boston, has clearly demonstrated that those adolescents with persistent dysmenorrhea, along with nausea and menstrual disorder, and especially this dysmenorrhea that occur at the same time of menarche, since, as I mentioned previously, the primary dysmenorrhea occur some months after menarche, usually with the gynecologic age of 6 to 12, when the cycle becomes ovulatory. But conversely, when this dysmenorrhea occurs at the same time of primary menses, we should pay attention to this dysmenorrhea, especially if nausea, I don't know why, don't ask me why, nausea is a kind of a risk factor, but a persistent dysmenorrhea, early onset of dysmenorrhea, and obviously, but everyone knows, some resistance to conventional treatment, anti-inflammatory. And so it's a new message. I'm sorry, in my opinion, it's very important, and it does make the link between pediatric involved in adolescent gynecology and adult gynecology interested in adolescent gynecology. It's a kind of new link between these two specialties. As I mentioned some years ago, it's exactly the same story for PCOS. In the past, we used to...
Certainly. Everything starts since the beginning. The beginning. Okay.
Exactly.
Adolescent gynecology is sometimes really the area where we can see what will happen in the future.
Exactly. It's exactly my message.
And then I have a question from, first of all, a question from Tatiana, but she's written in Russian, and I don't know the Russian language, and I cannot read. But for Stefano Luisi from Edda Pasinetti, there is a data for long time progestin treatment and breast cancer risk. You know the topic, in particular for Dianogest.
That I know there is no long treatment and the risk of only progesterone. Also because Dianogest don't have on the breast no data about the risk of breast cancer.
Thank you. And also now for another from Charles, you were mentioning that one is an anonymous, which is asking, what is the role of the genetics in adolescent dysmenorrhea?
Okay, there is no, unfortunately, extensive genetic studies. The only thing, the only data that in which we should pay attention to, it's a gene polymorphism that have been reported in adolescents with dysmenorrhea. It's a brain-derived growth factor gene polymorphism that has been associated, but so far there is no extensive data. But it's a good point. I remember in my clinic, I used to manage familial dysmenorrhea. The mother came with two daughters, both of them had dysmenorrhea, and the mother used to say, I had dysmenorrhea. There is some, specific milieu, specific environment. We may have some genetic background, but we don't know how much it interferes with the development of, but there is a specific phenotype. I'm sorry. Usually, have seen thousands of girls with dysmenorrhea. It's adolescent with not obese, but a little bit overweight. She's not very happy. She's used to, she doesn't practice exercise. She doesn't have a good self-esteem. You understand what it's a specific phenotype. So in my opinion, this could be based on the genetic background too, but I don't have evidence. It's just a clinical feeling.
We have several questions that I put together, which are related. Stefano, you can answer. There are questions related to the patients who, for the causes of severe endometriosis and adenomyosis, they go to an hysterectomy and sometimes also to an adnexectomy. And then they have premature menopause. The question is, can we treat the premature menopause in the patient which was operated for an hysterectomy and adnexectomy for endometriosis and adenomyosis?
A good question. This is a good point because in the 10 years ago, when we make a hysterectomy for endometriosis and also an mastectomy, in this patient there is the premature ovarian failure. But the recent data about 5 years ago showed that probably if we give the HRT for the menopause, we have a increase of the foci of endometriosis, because when we have endometriosis or adenomyosis, is not only endometrioma, but we have the endometriosis in bladder, in uterine ligament. So it's very difficult to understand if we can give the best choice is a good counseling with our patient, because also if she go in premature ovarian failure before 15 years, is very important probably to go to give estroprogestin. Thank you for the question.
In a combined way without the menstruation, then you don't need to have a menstruation, but you have to maintain a control also of the progesterone. You have also to stimulate progesterone receptor. This is an interesting question according to the clinical aspect of the disease.
Yes.
Sure.
If I can give my comment also, is that now is very important to medical treatment, and not when we have endometriosis or also adenomyosis, surgery, make the surgery. And when we have the patient have less than 50 years, please don't remove the ovary, because the problem is not only in the 5-10 years, but after, for cardiovascular, from Alzheimer and other nervous system disease, and also for osteoporosis. Thank you.
Thank you. And then now we are approaching to the end. We have a question for Sultan from Exiaxia. I have two questions. One is for Professor Sultan and the other for Professor Luisi. The first is for Professor Sultan. Dysmenorrhea seems more prevalent during 14-15-year-old, according to the epidemiology of your team. Do you think that progesterone level is lower during the age of 14-15, or lower activity of progesterone receptor?
Now, as I mentioned, as I previously mentioned, and we report epidemiological data 30 years ago, in which we clearly demonstrate that prevalence increase with gynecological age. That means that dysmenorrhea does occur only if menstrual cycles are ovulatory. If the cycles are not ovulatory, such as in the early months of after menarche, we don't have dysmenorrhea. So dysmenorrhea is related to the drop of progesterone when cycles are ovulatory. And that's the reason why prevalence slightly increased from gynecological 1 to gynecological 3. That means for 14 to 15 or 13 to 15 years, and then it's slowly declining in the age of 16 to 17.
Thank you. Then, I'm sorry, absolutely yes. And then for Stefano Luisi, the question from XXIA was how you treat the adverse uterine bleeding after oral Dianogest?
Can you repeat, because we have a different
how you treat when you have adverse uterine bleeding after oral Dianogest, if you have?
If you have
adverse uterine bleeding.
Yes, I treat with probably with some with 1 or 2 weeks of estrogen, and then give again Dianogest. I think that is very, very less percent of women that have bleeding. There is no bleeding mass spotting, with my experience.
And then also I take the opportunity, also Gianluca Albanese is asking about the risk of undesired pregnancy. Should you use another form of contraception in patients under treatment with Dianogest?
If there is the risk of pregnancy?
Yes.
Yes, we know that Dianogest is also a contraceptive method. So if we have a good counseling, we can say to our patient that the pregnancy is the possibility of pregnancy with Dianogest is very low.
Then one question from Tatiana, she wrote in English. The question, Charles, is what do you think about myoma and adenomyosis? No, I'm sorry. This is for Stefano. What do you think about myoma and adenomyosis and the Dianogest?
It's a good question from the colleagues, because it's very difficult to understand that there is a fibroma or adenomyoma. So is to give Dianogest probably in adenomyosis is okay, but adenomyosis, fibroma, I don't know if there is the good choice.
Then, okay, then a question for Charles Sultan from Maria de Pilar Navas from Costa Rica. She's asking, with the bone in adolescent with progestogen only contraception, not for endometriosis, what is the possible risk of endometriosis? The effect
the risk of endometriosis.
The risk, no. When you give progesterone only contraception, not for endometriosis, but in a young adolescent, there is a risk with the bone.
You know, it depends of the age of the adolescent. It depends of the bone mineral density when you start the treatment. And it depends on the activity of the pituitary gonadal axis. If this kind of progesterone has, I should say, mainly a peripheral action on the uterus, there is no risk for bone. If there is an impact on the pituitary gonadal, it may slowly decrease, and has been evocated previously. I think percutaneously or an estradiol patch simultaneously could prevent this decrease, as I mentioned before. That was a good suggestion, and I confirm that that would be better to add a patch from estradiol patch.
Thank you, dear friend. And now we are at 5 o'clock, and then we are at the end. And then I would like to ask, we will go first Stefano and then Charles. We will go in the different order to make a final comment. You know, we have our public, we have still more than 600 people present with us, more than 600 after half an hour of general discussion. And they were here to hear from you, from Stefano, the impact of progesterone and progestins in endometriosis and adenomyosis, and the impact from Charles in dysmenorrhea. I would like to have you a final general comment and clinical suggestion for our participant. Please, Stefano.
Thank you, Professor Genazzani. My conclusion is that before medical treatment, that is progesterone probably is the best choice, is very important the diagnosis. That is the clinical diagnosis, because the symptoms regarding endometriosis and adenomyosis in these years are very important, and the patient has in our clinic that dysmenorrhea, dyspareunia, dyschezia, dysuria are very, and also abnormal uterine bleeding in adenomyosis. The second, after the anamnesis, the clinical symptoms, is very important, the diagnosis. And as previous say you, in Italy, there is a lot of colleagues that use and have a good optimum diagnosis with ultrasound transvaginal echography. And then when we have a suspect of endometriosis or adenomyosis, the medical treatment is the best choice, because for example, if we go to surgery and we have an excision of endometrioma, that ovary is ovary that produce less oocyte. So when we have a women that after 5 years want a pregnancy, is difficult. And at the same time, the medical treatment is important, because also not only the part of the pain, the dysmenorrhea, dyspareunia, but also the inflammatory, because if you have make a laparoscopy, you know that there is also the gland, the inflammation, and there is the alteration of also the mechanism of the tube, for example. So before I see a question if there is the complication of endometriosis, the extrauterine pregnancy, is true, because the tube don't have the normal line, and so is more. So it's very important these 3 steps: clinical diagnosis, and at the end the medical treatment. And probably now in these years the progestin is the first choice. Thank you.
And then Charles, it's your role, speaking about you are a master of adolescent gynecology, and then the dysmenorrhea as a symptom that something can be present in the dark and can be of risk, put at risk all the female life of that young adolescent. Please, your final message to give us your view to our participants, please.
You just gave the message. Do you hear me? Yes?
Yes, yes.
I think you just gave the message, the main message. Now, more seriously, thank you for your invitation, because I'm convinced that many of our colleagues within these 2 lectures have learned of a new vision of the usefulness of progestogen. 2, regarding more specifically adolescent dysmenorrhea, the first message is a syndrome. Dysmenorrhea is a syndrome that could be evaluated and quantified, because sometimes adolescents say, I have a dysmenorrhea, it's just a pain or dizziness or excitability. Anyway, so it must be quantified. So it's a syndrome, but it can be also, as you report, it can be a symptom of an underground disease such as endometriosis. Two, the second take-home message. Many adolescents use self-medication. And in some reports, this self-medication are effective strategy in many cases. So I would suggest to continue if this self-medication, alternative therapy, complementary therapy are useful, please do it. Because as I mentioned, this kind of approach mainly manage I should say, the psychological environment, and yoga, acupuncture, transcutaneous electrical nerve, and so on. If they prove helpful, do it. But if it doesn't work, don't stay with your dysmenorrhea for many years, since it does induce absenteeism. And the cost of absenteeism have been evaluated in the United States, and it corresponds to millions of dollars per year. So it's a serious condition among teenagers. And as I mentioned, grading is very important. The treatment is well defined. First line, non-steroidal, and after this approach is dependent on the adolescent needs or not contraceptive pill. If she doesn't need contraceptive, I should use progestogen. If she does need contraceptive, I would prescribe oral contraceptive with, as I mentioned, this particularly progestogen. And last, if this dysmenorrhea are persistent over 2-3 years, I should pay a little bit more attention and ask for the advice of a gynecologist or gynecologist endocrinologist. That the main message and the new message, or on the recent message on adolescent dysmenorrhea. And thank you again for your invitation. I was pleased to share this session with my colleagues.
We have also to thank the generous support with an unrestricted grant of Abbott, who have permitted the translation of this fantastic webinar to 7 languages. The seminar is in English, but as you have seen, we have 6 lines of different languages going at the same time. And then I would like to thank, because this was, it's not common to have so unrestricted grant.
Congratulations.
Just for the education. I thank very much Abbott for that. And then, dear friends, I would like to thank Stefano and Charles and all of you for being with us. We will go, I would like to close the session, and we will go to the next lesson on that next part of this webinar on the role of progesterone in menstrual cycle related disorders. And next time we will have the Professor Eftimios Deligeroglou from Athens and the Professor Rossella Nappi, who will speak. They will be the 2 speakers of the next webinar on the role of progesterone in menstrual cycle related bleeding disorders. We have spoken today of pain disorders. We'll speak about of bleeding disorders. This will be the 16th of June, still at 3 o'clock European Central Time. Thank you very much. Thank you for being with us. And then I invite all of you also to join us the 11-14 of May, we will have the 20th World Congress of the Gynecological Endocrinology organized by our society, ISGE. We will meet in the 11-14 of May in Florence. I invite all of you. It will be a fantastic event full of new investigation, new treatments for patients, new diagnostic procedure, and mostly, I wish for you a healthy time in a beautiful location. Thank you very much.
Thank you.
Thank
Goodbye,
you.
Charles. Goodbye.
Bye-bye.